Hi, my name is Haley, and I'm currently completing my 431 community placement at Luther Towers. The Luther care team consists of the pastor, social worker, nurse, and tenant service coordinator. But the day we were there, only the social worker and the nursing student team with our instructor was present. It starts with patient X phoning down to the social worker, stating she is feeling unwell and dizzy. The social worker informs the nursing student team, and my instructor and I decide we will go up to see her. But we continue on with pre-conference and talk about how a different student is going to go see room 701. My instructor and I go up, having the number 701 in our head, and go to room 701. We knock on the door, we say, "Good morning, patient X," in which she invites us in. We explain that we're going to do her vitals and assess to make sure she is feeling well, which she's agreeable to, and we complete vitals and subjective questions and find that everything is good. But there were some confusing answers, such as she hasn't felt dizzy in months, she never phoned the social worker, and the social worker never phoned her. So in this moment, my instructor and I realized that we have gone to the wrong room. We politely dismiss ourselves and head up to room 907. When we knock on the door, she's definitely exhibiting some signs of dizziness and low energy, as well as a blood pressure of 105 on 72, which she was unable to remember if this was her normal or not. But she stated given her age, as well as her chronic conditions, she would prefer not to have any further medical care and just wants to live out the rest of her life peacefully in her apartment. So as a team, my instructor, me, and this tenant decide we're gonna come check her vitals one more time around noon, and we'll make a plan from there. But when noon rolled around, my instructor and I were both busy, and neither of us went to check on this tenant. But given the fact everything was normal at 8 a.m. when we checked on her the first time, we did not inform anybody. Later that afternoon, around 4 p.m., the daughter came in and was frustrated that she had not been informed that people were checking on her mother. So my instructor and I went to review the policy, which stated in order for a tenant to be able to live in this building, they need to be able to recognize their need for medical care and their need to inform somebody if they need it. Upon taking the past couple of days to reflect on the situation and how it could have been prevented, the main idea that came to mind with going to the wrong tenant's room and allowing her allowing us to assess her for 15 minutes without question was the idea presented in standard 4.4 of the CHNC competencies, which talks about the power dynamics between healthcare professionals and clients, which in the situation was very clearly unmanaged, and there was a strong power differential as the tenant did not feel comfortable speaking up that we were in the wrong room and just went along with us, despite the fact that due to her full cognitive function was definitely aware that something was abnormal. This also fits into standard 411, which talks about the importance of the 6 interprofessional competencies, which there was definitely a problem with role clarification leading to the daughter's frustration. Since the tenant service coordinator is normally the one who mediates the conversations between tenants and staff and tenants and their families, and she was away sick, there was no clarification between the social worker and myself to know who was going to phone the daughter of this abnormal result, and nobody ended up phoning her, resulting in the daughter's frustration as she felt like she wasn't being a valued member of her mother's care team. Within Standard 8, Competencies 8.2 and 8.3, we as a team recognized that there was an ethical dilemma related to the daughter not feeling included as part of her mother's care. However, we were under law-abiding obligations to not break patient confidentiality, as we had no consent from the mother to share this information with her daughter. However, we as a team, including the social worker, myself, and my instructor, reviewed the policy related to talking to emergency contacts about their loved one's medical information. The policy stated that it is not within our legal right to talk to emergency contacts unless it is a matter of life or death. So despite the fact that we made the right call in this situation, the outcome was not what we had desired. So this could have been enhanced by interprofessional communication between myself and my instructor, knowing the policies under the agency we operate, which then would have allowed us to better involve the daughter in her mother's care. Despite not giving information, we could still have included why we couldn't and reassured her that now her mother was doing fine without breaking any confidentiality rules. But I was able to later get consent from the mother to talk to her daughter about what had happened the day prior, in which I was able to take out the documentation I had done immediately afterwards and review it with her, which eased her state of mind and fits into competency 810, which is the importance of documentation that right after an event and is clearly and concisely written. The third most prevalent standard in this situation was standard 1, when it talks about the importance of doing a thorough assessment and then following up on that assessment to make a plan moving forward that is client focused. So in this situation, my instructor and I had promised that we'd come back around lunch, and that ended up not happening. So this not only failed our ability to follow up on a plan and do a thorough assessment, it also broke trust between tenant and healthcare professionals now and potentially in the future, as we did not stay true to our word and provided no follow-up information as to why we were gone or an apology that we did not stay true to our word. So this was poor collaborative leadership between us as an interprofessional team and sharing that leadership with the client themselves, as they had no say in what was happening. It was just all us telling them that we're going to come over and then we're not going to come over, and we had complete control and complete power over the situation. After reflecting on this situation, my goal is that by the end of my time at Luther Tower, all of the staff will understand that it is the tenant's job to report and recognize any illnesses or injuries that are not life-threatening, and that it is their responsibility to inform their family and friends or whoever they think needs to know. So I will do this by presenting a quick review for staff at the interprofessional meeting that happens on Wednesdays related to this policy, helping the staff achieve this by creating information for the residents, which includes a student blurb before our presentations that we do weekly, as well as an infographic that we can place in high traffic areas such as the recreation room, the announcements boards, the elevators, or up in the dining hall with permission from the company that runs the dining room, as well as providing one-on-one education with tenants when we go around to the flu clinic and we interact with all the tenants, providing education prior to the pharmacists administering the vaccines. I would also want to educate the staff in the interprofessional meeting about the importance of continuing education when situations arise where the tenants overly rely on the staff.